people. Um, it is there's 42 people who provide critical care in my group, 42 attending intensivists, 10 advanced practice providers, another 20 fellows, and then loads of trainees and many nurses we work with. So the opportunity to work with people with many different perspectives, and that's helped inform my experience. Disclosures very clearly: the pain agitation and delirium guidelines in 2013 came out, and they were very informative for critical care practitioners. There was a follow-up to those PAD guidelines in 2018. Devlin is a pharmacist who is the lead author, and like the surviving sepsis guidelines, which sort of revisit each topic in sepsis each year as the guidelines are updated, the PAD guidelines are more of a service building blocks going forward. Again, like guidelines, when you're an intensivist, guidelines are the baseline of what you do. As an intensivist, you are a person who interprets those guidelines and applies them to the bedside. So that'll be what we talk about today. I think it's important that the liberation bundle is a fundamental part of the care you provide for patients in the intensive care unit. The ABCDF bundle is it's affectionately termed in the United States. So we'll be going through elements of it today, but I think that this framework is an excellent framework for providing care for the critically ill. We'll start with a case. A 46-year-old male is intubated for respiratory failure due to pneumonia. He's writhing in bed. The team does not understand why. When he was awake, he was very reasonable. The team calls his wife, who says he has known severe back pain. So, the first part of the talk will be focusing on pain. I think many times patients have unrecognized pain that plays a significant role in the difficulty in sedating them when they're critically ill, or them becoming desynchronous on the ventilator. The definition of pain is the unpleasant sensory and emotional experience, and pain should be considered whatever the person experiencing says it is, whenever the person's experiencing the pain. Obviously, this talk will have an American perspective. I want to acknowledge that. The U.S. has had a significant issue with opioid overdoses. You can see here since the early 90s, this is to the early 2000s, there was a significant increase by the millions of opioid prescriptions. This is a map of the United States showing where the opioid crisis is the worst in the world. You can see here, I don't know if you can see the cursor, but this is where I practice in the southern region of New Jersey here, and we have a dark area here. So recognizing that the overprescription of opioids for the treatment of pain or perceived pain is a significant problem in the United States and problems around the world. In some counties in the United States, it's the third or fourth leading cause of death. And certain states, if you look at West Virginia, there's areas where it's amongst the top two leading causes of death. I think when you're thinking about pain inside the intensive care unit, you need to recognize that anxiety, depression, uncontrolled psychological symptoms prior to coming inside the intensive care unit are exacerbated by your illness in the intensive care unit. It can make pain worse. And taking a good history, speaking to family, as was placed in the first case vignette, is an important part of that conversation. There are things we do in the intensive care unit that cause the patients to have a significant amount of pain, which is, the turning is something that's very commonly patients cite as one of the most painful experiences while in an intensive care unit. How do you use opioids to manage pain in that reason? Do you have somebody on scheduled opioids, or do you give them PRN opioids prior to doing something that may be perceived as painful? This was one of the seminal studies about evaluating pain in the critically ill. Came out in the mid-90s. It was about 5,000 patients, and they asked them, how much of the time do you have a pain? How severe is the pain at present? How, are you satisfied with the degree the pain is controlled? And what they saw clearly is that patients, majority of the time, were not having their pain well controlled, and that 7 out of 10 patients get reported being in pain a majority of the time. This led around the same time to say that we should make sure patients are not in pain. In the United States, there was a movement that started in the mid-90s that pain was the 5th vital sign, and it led to a significant amount of opioids being used for pain for the critically ill, at least in the United States. There's a name you should know if you look in pain, agitation, and delirium guidelines. It's Buntillo. She's done a significant amount of research on pain, agitation, delirium. One of the things she's researched quite a bit is procedural pain. Surprisingly, I'll tell you, when I came up as an intensive, so I would think putting a chest tube in a patient would be more painful than taking it out, but pulling a chest tube out, placing an arterial catheter, and doing suctioning patients who are endotracheal intubated are the 3 procedures most cited as painful amongst critically ill patients inside the intensive care unit. This is barring, obviously, somebody who may need an open laparotomy at the bedside or a sternotomy in the cardiac surgery patient population. But these are for patients who are, intubated, may have medical, or may have had elective surgical disease. People talk about being the most painful procedures. It's interesting about an arterial line, why arterial lines are so sensitive. The radial nerve is there. I think that many times people end up hitting the radial nerve, numbing a patient with lidocaine, using adjuncts to avoid pain. When you're pulling a chest tube out, adequately medicating the patient, pain medication, or using other adjuncts. And we'll talk about that a little bit as we go forward. I think you cannot talk about pain or think about pain in a qualitative manner. You have to use a quantitative manner. So you'll see from the talk that I'm giving you today that quantification of pain, agitation, and delirium is mandatory. And what scale are you using? So a commonly used scale inside intensive care units in the United States and intubated patients is the behavioral pain scale. It doesn't matter what scale you use. You should have a scale that you're, as physicians, that you're aware of, and that you work with your nurses to make sure that they're using that and not just saying, hey, yeah, he looks like he was in pain, so I gave a fentanyl bolus, or I gave a Dilaudid bolus, or I gave a morphine bolus. But actually, oh, the pain scale is elevated and I've decided to intervene. And now I've remeasured the pain scale after the pain medication was given, and I can see that the patient's pain score has gone down significantly. Another scoring system is the CPOT scoring system, and it's patients who it's just another way to quantify pain who are intubated, and it's an excellent scoring system. It's been validated a multitude of times, so these are tools that you can use in different contexts. What is not useful to evaluate pain is our vital signs, and 4 clinical studies, and I think overall, 19 clinical studies, if you refer to the guidelines. Vital signs are not an accurate reflection of patients having pain. So if you have somebody in the intensive care unit and their pressure goes up, and the first thing you want to do is say, okay, you know what, I think they're in pain, let me give them a bolus of a narcotic. I want to say that there are close to 20 studies that say that's the wrong thing to do. What you should do is use a validated pain scale system to assess whether they're in pain or not. And this has been extended into using end-tidal CO2 and other adjuncts. Vital signs are just not, when used alone, a reliable measure of pain in the critically ill. Family, that was one of the first things that I spoke about today, is that getting information from families is very, very important. Another thing that's important is that families are better able to identify pain in critically ill patients who are intubated, sedated, as opposed to physicians or nurses. There is somewhat of a tendency for family to overestimate pain, but they are more accurate in identifying it than bedside clinicians. And then you'd say, okay, why is this important? Why does this matter? We know with effectively treated pain that patients are more likely to, less likely to self-extubate themselves, harm themselves during treatment, and also more likely to be compliant with the ventilator, as a few simple measures. I've been talking about opioids quite a bit, pharmaceuticals, what's the role of pharmaceuticals in treating pain? Understand the Tanzanian context, that fentanyl is one of the primary agents used in NSAIDs. So we know opioids biochemically will affect brain. There's obviously the opportunity to use local anesthetics with both nerve blocks and epidurals, or even field blocks. And then, there's peripheral nerve receptors that you can block. This concept of using more than opioids to care for, to treat pain is something that we had in the United States and then was lost for a period of time and then was found again. There's a nice study here that was done in 2021 that was looking at pain treatment, and what it shows is that in 1,500 patients, they had used two protocols in patients who've had significant amount of trauma. The first protocol used scheduled IV Tylenol, NSAIDs, neuropathic pain medications, and then an opioid, a light opioid, a tramadol and lidocaine patches as needed. The second protocol eliminated scheduled opioid and just used PRN opioid. And again, this is recently published, 2021. Data is a few years older than that, but 1,500 patients, not a small amount of patients. And we can see clearly here in the new protocol, the protocol, that the patients ended up having less opioid needed at discharge and a significantly less need for opioids while in the hospital. I want to acknowledge that in the context of practicing outside of the United States, that many times that people probably are, not necessarily all countries, but maybe better at using more narcotic-sparing pain regimens. But there's also data to support that thought process there. This is a systematic review, 2019, again, by Devlin and colleagues, and it's a multitude of papers. I think 9 papers cited here, but just looking at if you use adjuncts, acetaminophen, NSAIDs, or neuropathic pain medications in medical ICU patients or patients with neurological disease process, where primarily Guillain-Barré was looked at it. You can see here on the forest plot that it's these diamonds here is basically an overall summary of all the studies. So clearly that non-opioids are favored in the medical and the and the patients with neuropathic pain population. And the prior study I just showed you was also having a pain pathway or regimen that did not include opioids. Scheduled opioids also was favored in the trauma patient population. If you take a larger view of this, basically, there's a systematic review that looked at 10,000 records, and there's 34 studies that were included. And what you can see here clearly as you continue to go forward is there's also a role there's clearly a role with acetaminophen and NSAIDs, but there's also a role of something called nefopam. I apologize. It's not a drug that's available in the United States. It's a NSAID, but as the effect of feeling like about a couple milligrams of morphine, the same thing that IV Tylenol will feel like, and that patients would benefit from it. There also seems to be an analgesic effect to Precedex or dexamethasone, which we'll talk about today, which can be also used as your sedative and a pain regimen. The question is whether Precedex actually treats pain, or does it interfere with the receptors of pain in the brain, and that is pain actually being adequately treated. Now, the level of certainty on these papers overall are low, but there is a multitude of research over a period of time that seems to show that adjuncts from a pharmacologic point of view for opioids seems to make a difference. The same paper clearly shows light opioids like tramadol seem to help. We use ketamine quite a bit in our intensive care unit. We use it as a ketamine reset patients who are on a significant amount of opioids. Sometimes we do a continuous infusion of ketamine, and that allows us to significantly reduce the amount of narcotics they're on, and the roles of, again, neuropathic pain medications are clearly seen here in carbamazepine pain. But adjuncts, non-pharmaceutical pain regimens, what are the role of them? Massage therapy has been evaluated in the critically ill. It has been shown to clinically reduce the amount of pain patients are in. It does seem to me an obvious adjunct to caring for the critically ill. And it's also, you have to look at the resources you have. Manpower resources, at least in the intensive care unit in the United States, and the intensive care units are difficult to come by and very expensive. If you have resources to people who may be willing to provide massages to your patients, or you do some early range of motion mobility exercises, that may be cheaper than using heavy doses of pharmaceuticals, and definitely should have less side effects. The role of music in the critically ill and reducing pain has actually been well studied. There's a nice study out of Minnesota. Now there's a randomized controlled trial funded by the National Institute of Health in the United States that's ongoing, looking at the role of pain in reducing pain. It's role of music in reducing pain. It is clear that if you give music of the patient's preference, you can significantly reduce the pain that the patient is in. Again, a non-pharmacologic alternative that should be used as an adjunct. It is an adjunct we use in the intensive care units where I practice in the States. The role of ice packs, if you look at the, again, 2018 guidelines that talk about the use of using cold ice packs on the chest prior to removing a chest tube. If you put them on for 5 to 10 minutes prior to pulling the chest tube, the patients feel significantly less pain. We have moved towards using this in our intensive care unit after these guidelines came out 5 years ago. Another thing that we started to use in the intensive care unit, although the data isn't there yet, but I believe it is coming, is forms of relaxation therapy. We have a psychologist who rounds in our intensive care unit and works with patients who are not intubated, or intubated patients are able to interact about centering yourself and trying to work with people to control their anxiety, which I believe also will help them control their pain and put their pain in context. I think what's very, very important is that there's protocolized angiosedation. What you want to do is have an order set for the delivery of pain medications, and not just be giving pain medications based off of vital signs, but actually have an organized regimen. And the narcotics will need to be used. The How do you use the least amount of narcotics while keeping the patient synchronous with the ventilator? The protocols of anti-sedation will also improve the duration of mechanical ventilation, ICU length of stay, and you see here the pain intensity. So in summary, for pain, use families and scoring systems to assess pain. Use adjuncts to reduce opioid exposure, and make sure you protocolize angiosedation. And that's well studied. So on to part two. The same 46-year-old man admitted for respiratory failure due to pneumonia. He's writhing in bed. His pain's better controlled now. How he's difficult to sedate. The nurse wants to know if he can use dexmedetomidine versus propofol. As he heard, is better sedatives, is a better sedative in some patients. So let's go into the role of which sedative to use and why. First, just like with pain, you have to have a standardized scoring system to assess pain, sedation in the critically ill. You can use a RAS score, or you can use the SAS. RAS is what I'm most familiar with. I've used it in multiple hospitals. From deeply unarousable to extraordinarily agitated is how it goes. Simple scoring system. Also, when you're talking about sedation, you have to use the standardized literature, standardized terms that are defined in literature. A spontaneous awakening trial is the stopping of narcotics as long as his pain is controlled and sedatives daily. A spontaneous breathing trial is once the patient is able to have these meds stopped, or the patient has an adequate RAS. On low-dose pain meds or narcotics, you can do spontaneous breathing trial to see if the patient's able to breathe on his own in intubated patients. This is an example. You see, I put some red lines through it of the Wake Up and Breathe protocol, which came out of Vanderbilt almost, I think, close to 20 years ago now. You can see when you do a spontaneous awakening trial, if the patient fails the spontaneous awakening trial, you're supposed to restart the sedatives and pain meds at half dose. That protocol is almost 20 years old. It's still something that you need to emphasize all the time. But if patients pass the safety check, then you can do a spontaneous breathing trial and consider for extubation. I really like this. This came out in 2022. It's looked at, I think, close to 5,000 patients. So I think 4,800 in the spontaneous awakening trial group and 4,900 in the spontaneous breathing trial group. You can see from this forest plot, the odds of getting a spontaneous awakening trial was significantly higher in patients who were on dexmedetomidine for sedation. We're getting frequent arousal and assessments. Had basically using a sedation protocol. And then who had patients who had physical restraint use. And, generally in the United States, try to shy away from physical restraint use. Those sort of a curious finding, but there's a multitude of reasons why that may be true. I think what's really important about this is you can say, oh my God, we don't have dexmedetomidine. We don't have a lot of sedative drugs. What is clear is even if you don't have that, if your patient is not kept comatose, you minimize exposure to benzodiazepines, you do frequent arousals, you do frequent targeting of sedation levels, you will be able to do a spontaneous awakening trial. If you're able to do a spontaneous awakening trial, that's a lot more likely than you're going to be able to do a breathing trial and get the patients extubated earlier. And we know getting patients off the ventilator earlier improves all-cause mortality, decreases ICU length of stay. And it's, the primary reasons intensive care units exist around the world, at least for recreation, was because of the development of mechanical ventilation. So decreasing the use of mechanical ventilation will open up your intensive care unit for other patients who need to get in. Which medications, there's a multitude of literature. I can't remember the exact number, but I think it's at least 5 trials that looked at Diprivan versus midazolam, benzodiazepines over and over again. Midazolam leads to longer length of stay, more delirium. There's even data about increased mortality of using benzodiazepines versus propofol. The only thing that I would say is, perhaps you don't have access to anything else but a benzodiazepine, then use your benzodiazepines. Try to keep the patient's RASS level 0, minimize exposure, use adjuncts like behavioral medicine, like trying to help patients control their anxiety, and that may be difficult when somebody's intubated. Using music, which also helps to control pain, but will also help to address sedation. Again, same thing with dexmedetomidine versus midazolam. The data more shows that it's equal as far as getting patients off the ventilator, but the guidelines recommend using dexmedetomidine because of harm that has been known to from benzodiazepines. So benzodiazepines should be used infrequently or last resort, provided failure of either Precedex or dexmedetomidine or propofol. The reason, again, that dexmedetomidine is recommended over midazolam is I think this was the SEDCOM study in 2009 that you could show that dexmedetomidine led in these Kaplan-Meier curves to short time to extubation and decrease ICU length of stay versus no. So this is shown over and over. Again, propofol versus dexmedetomidine, the data has never really been able to bore out which one is better. So both are fine options. I'm sure more probably retrospective literature will look at this as time goes forward, but they both have their advantages and disadvantages. Restraints. The reason we use restraints in the critically ill is to stop patients from harming themselves. And again, in the United States, there's a big focus on using less restraints, which I think is important. But what's important here is to participate in having patients participate in early mobility and recognizing patients with history alcohol use. You'll be able to treat that, and then you'll be able to have patients in less restraints, because overall restraints are not beneficial for patients for a multitude of reasons, including patients having post-traumatic stress disorder, post being in the intensive care unit. And they're actually, in many ways, have been noted over a multitude of years of studies to be ineffective form of restraint of keeping patients safe. So sedation. The way I view sedation is keep it as light as possible. You want a RASS score close to 0. Use a protocol. Do not use benzodiazepines. If that's all that you have, then use them sparingly. And there's a conversation always in the medical literature of daily sedation interruption versus a nurse-driven protocol. So like once a day you stop the medicas versus nurses all day looking at the sedation, trying to keep it as light as possible. I strongly support a nurse-driven protocol. It's not necessarily supported in the literature, but independent autonomous nurses help patients get better. And I think it is a good way to care for the critically ill. All right, so the last part, and then I hope we have the opportunity to have some discussion. A 46-year-old male is intubated with respiratory failure pneumonia, same patient. RASS score is -3. He lightened sedation. He's grossly agitated, but you can be oriented. Include his delirious, and then the nurse asks you to add an antipsychotic. So the question is, what do you do here? So just taking a global view, this is one of my favorite studies. It was a survey that was done in 2017, looked at 1,500 patients, and it just, it looked at the continent of Africa, Asia, North America, South America, so the whole world, and saw what people are doing. And what was excellent is 83% of respondents use a scale to evaluate pain. Early mobilization was prescribed, but most didn't really have a team to make it happen. Members were involved in 7 out of 10 ICUs, which is good. But there wasn't 24-hour availability to the patient's families. And so in some ways you had the protocols or you had best practices, but you didn't have the ability to implement them, or there wasn't a true commitment to implementation. And, the question is, does that have consequences? So here, if you look at these slides here, there were 43 respondents from the continent of Africa and 440 from Asia, North America. We're going to focus these questions on Africa here. So do you routinely monitor delirium? So the parentheses is percentages of the 43 respondents. A significant number said that you do not routinely monitor delirium. So an opportunity, this is in 2017, say, okay, delirium needs to be examined more in the intensive care unit. Then what tools do you use? There's no tool that's being used many times. And this is, again, the people who responded from the continent. The CAM ICU is a tool we've used quite a bit inside our intensive care unit in the United States. It's excellent. People view it as cumbersome, but I don't feel that it's that cumbersome. But I spent a lot of time trying to teach people how to use it, and I think it makes a big difference. And patients who you think are delirious turn out not to be delirious, and that will change the way the nurses use sedation and pain medication, and will change the trajectory of that patient quite a bit. And then you investigate the cause of delirium, but you don't really know the patient's delirious, not because many times people think they're delirious, but they're not necessarily. So this investigating the cause doesn't make a lot of sense. And then this question is, how many patients have delirium in ICU? Well, if you're not using a standardized tool to assess delirium, then how can you know how many patients have delirium in the United States? So I think there's a lot of opportunity to use the CAM ICU, at least from this 2017 study. So I'd be curious today to speak to you guys to see if you guys are using it in your intensive care units routinely. And there's one thing about having it available, people have familiarity, and people actually using it at the bedside. Just other, quick hits from this study. Earplugs are a way to reduce pain. Very few people are using earplugs in the African context. Light optimization is something that people seem to spend more time doing. And do you have a protocol to manage delirium? And I think that's all very important. Like, delirium is common. It is associated with worse outcomes, and it's something that you should spend time using. Now, this question of pharmacologics, are you using Haldol? You're not using Haldol. So it seems to be, at least in the African context, that Haldol is used. Seroquel is not used, quetiapine, which is good because there's not a lot of data to support it. Haldol itself also has some issues. Quetiapine is an atypical antipsychotic. So this is the CAM ICU. So we'll spend a minute on this. So it's the confusion assessment method for the intensive care unit. So when you evaluate your patient, do they have a change from the mental baseline? Has the patient's mental status fluctuated in the last 24 hours? The answer is no. So they're not delirious. If the answer is yes, then they have to get 2 errors to say that they are delirious. So you ask patients to squeeze my hand when I said the letter A. If patients don't speak English, there are alternatives in other languages. This has been translated into other languages. I would suggest using that. If they have greater 2 errors and their RAS is greater than -2, then it's clearly that they're delirious. And then you can ask these simple questions of Snowflake. The whole assessment to me takes between 1 and 2 minutes. I highly recommend that you do it. The majority of delirium is hypoactive. If you look at large clinical studies, 90% of delirium is hypoactive, again, which is why many times it is missed. And there are significant consequences that are associated with that. They're fixed and modifiable risk factors for somebody being delirious. High level of severity of illness when you come into the intensive care unit is a fixed risk factor for being delirious. So if you come in with severe septic shock, there's more chance of you being delirious than if you come in with a simple pneumonia and you just require some oxygen therapy. So that's a fixed risk factor for delirium inside the intensive care unit. Modifiable risk factors is blood transfusions, which also may be not necessarily the blood itself, although there is a possibility of it because the cytokine storm that blood seems to induce, but is a modifiable risk factor for delirium in the critically ill. Again, benzodiazepines. And this is where a lot of that literature that's come out about delirium in 20 plus years is that benzodiazepines induce delirium, increase mortality in the critically ill, and should be used sparingly as possible. That's been a major advancement on this side of the ocean over the last 20 years. So what's the role of haloperidol and risperidone, or ziprasidone for delirium on critical illness? And this was a good study called the MENS-2 study, published by Tim Gerard out of Pittsburgh. And what it shows is whether you use an atypical antipsychotic or haloperidol, it does not affect the days alive without delirium or coma, days with delirium, or the days with coma overall, showing clearly atypical antipsychotics and how do not work for delirium, and that they shouldn't be the standard of care. So what does work, right? So what you need to do is actually look for the etiology of the delirium. So you can see up top here, it says perform a delirium assessment versus by the CAM ICU. Consider the differential diagnosis. And you can see on the bottom, they have something called Dr. Dre here. And you can think about the toxic situations like patient hypoxic, non-pharmacological interventions, the electrolytes, and then try to intervene. There is no pharmacological treatment for delirium that's been proven effective. There was a small paper by John Devlin that shows quetiapine reduced the number of days of delirium. That's never been able to be replicated. I will acknowledge that I will use atypical antipsychotics at times after all other non-pharmacological measures have failed, and I'm trying to wean the patient from the ventilator and unable to get off sedatives. I do think this is important. I don't think that people do this enough. We know that restraints will promote delirium. We know the patient's sleep is disturbed, and we need to protocolize. I have a sleep protocol. You keep on hearing me talking about protocols, because I think that these types of things, if they do exist, we've recognized that are important for the critically ill. That I do this, that if patients who are recovering and able to be awake on the ventilator, I will sometimes get them crossword puzzles to play, or try to engage them if they are able to try to unscramble their mind after they've been critically ill, to help them wean from the ventilator and minimize excessive noise and stimuli. This is something we struggle with quite a bit. Our intensive care units are very loud, and there's even conversation about building smaller intensive care units and being, as opposed to these large structures, to keep noise at a minimum. This is also important for the nighttime group. It's sometimes difficult to practice at night. You're loud, you're having fun with the patients there and trying what we're able to do. Early mobilization also is very key here. So early mobility. Early mobility has been a bugaboo. There's been quite a bit of discussion and disagreement about whether early mobility helps or does not help in reducing delirium in the critically ill. I'm on the side that it does help. I've seen it help a multitude of times and made a difference. It hasn't been able to play out in large clinical trials of late. But just if we want to take a few minutes with the facts, you can show that during ICU stays, critically ill patients can lose up to 25% of their peripheral muscle weakness. By day 4, they lose a lot of their body weight, and this process really is high in the first couple of weeks of immobilization. And I think, and I don't know for a fact, but if you look at the epidemiological studies of who's in intensive care units in the continent of Africa, you can see that a lot of times it's young people. So getting young people through their intensive care unit and they're significantly debilitated and they're delirious, if you have the ability to make them less debilitated and less delirious by mobilizing them early or engaging them early, it seems like the smart thing to do. You can see clearly here by implementation of the ABCDF bundle, which is all elements of the bundle, early mobility being one of them. This is in 15,000 patients, a retrospective review. You can see by the p-values here, there's less time on the ventilator, less delirium, less pain, less use of restraints, and less ICU readmissions. Which is why I keep on emphasizing the ABCDF bundle and recognizing that the early mobility is a key part of that bundle. Just displayed in another way here again, you can see it's all favorable for the more of the bundle, ABCDF bundle you perform, the higher likelihood the patients are to benefit from ICU discharge, hospital discharge, and you can see on the final over here to the right, the less likelihood that the patient is going to die. So highly recommend having an organized mobility program inside your intensive care units, even if it's just passive range of motion and the critically ill, but as they wake up and engage, being able to do more. Also, I'll say that there is a role of families. Families are grieving or at the bedside. Can they do some passive range of motion? It's one way for family to be engaged. Is another way to hopefully reduce some peripheral edema as the families work with the patients. Come back to family engagement again. That's the last part of the bundle. Again, I'm talking about delirium. Why am I talking about it? Is there a role of family engagement in reducing delirium? This is something from the American Thoracic Society. This is a free resource for family engagement, updated during COVID. One of the things they talk about is the roller coaster families are on while their loved ones are in the intensive care unit. Family, you need to have, in the United States, sometimes it becomes conflict because patients are critically ill between the medical team, surgical team, and the families. It's not going to work out if you're in conflict. What you need to do is try to be on the same page and working on it. Even the relationships tense, the families are going through quite a bit. That people talk about the second victim when you make a mistake. The families are the second patient. You need to engage them, recognize their suffering, and work with them. And what is clear here is you have a protocolized, again, I'm using the word protocol, but protocolized way to meet families, engage with them in a uniform manner, and talk with them that patients benefit. There is lower mortality. If you look at this review of 4 studies and lower ICU length of stay, showing that there is key information that can be gotten from families, and families will be partners in helping you get your critically ill patient better. But it is it's actually borne out in the literature. Now, it's not necessarily a ton of patients, but it's a lot more than 0. Close to 900 patients. I highly recommend going on this website. I think if one has a conflict or, sometimes is, weighing the benefits of medicine and whether medicine has helped or harmed people. I think one of the reasons I became an intensivist is you can see clearly when you engage patients who are critically ill, you can make a difference to get them better faster than patients on the medical floor or patients as an outpatient. But we do have processes that can be harmful to patients, and it's important to know that we need to stop that. Wes Eli has been sort of the leader in the delirium work and all the work, these PAD guidelines. It talks about not harming patients, not using benzodiazepines when we're able to, engaging families using non-opioid adjuncts to help treat pain. And so I recommend going on this website, ICU Delirium. There's a wealth of information that can be useful for you to care for your patients. Again, the ABCDF bundle, if all used together, shown in about 15,000 patients to make a significant difference on mortality, ICU length of stay, and discharge. And anyone who practices critical care knows it's hard to push the needle on reducing mortality, so it's important. So in conclusion, use adjuncts to reduce opioid exposure in your patients, keep sedation light and use a protocol, and implement the ABCDF bundle. It may be difficult, but it makes a difference for patient outcomes. So I said a lot, I ran through a lot in this time period. I know I talked fast, but I'm open to conversation or any questions people may have. And if not, I'm sure I got some questions for you guys. Thank you very much.
Thank you, Dr. Nitin, for that talk. I think it's quite enlightening. You went from the basics and then went into specifics. So that was good. And I'm glad that you touched on the importance of measuring all these issues that you talked about. Just like we measure vitals regularly, we should be measuring pain, sedation levels, delirium regularly, and especially using standardized tools that you alluded to. I have a couple of questions that I have received, so I'll just go through them. The first one is about the use of haloperidol. I know you touched on it, but there's a question that says that do you support the use of haloperidol in the management of ICU delirium, considering that it is associated with side effects after discharge?
Yeah, so the question is should you be using haloperidol for delirium in the critically ill? Is that essentially the question?
Yes.
Yeah, so I think you can't have a hard and fast rule where you say, no, I'm never going to use it, because sometimes you need to use it in an emergency situation, but it should not be part of your routine armamentarium. There was a really nice Chinese study that came out, it's probably a decade now, where they gave a couple milligrams of Haldol to all the patients who were being admitted into their intensive care unit. And it really didn't make a difference at all in patient outcomes. There's a large number of patients, and it's been borne over in study after study. And there are risks, right? It prolongs your QT, could lead to torsades. I think in general, antipsychotics, atypical antipsychotics may be used, but all other adjuncts should have failed, or should be an emergency situation where you need to sedate or have a patient better controlled in a moment of crisis. I will also say in the United States, there's something called the Food and Drug Administration. Our atypical antipsychotics have a black box warning for sudden death for being used in patients with schizophrenia or psychiatric disease. And now we're using these medications off-label. There is no indication for Haldol, atypical antipsychotics in the critically ill. And we use them off-label in patients who don't have normal pharmacokinetics, right? Because they're critically ill. Like, there's not a lot of data on like what's the pharmacokinetics of Seroquel and somebody on, norepinephrine and propofol, and it can be very, very dangerous. I'm not saying we don't use them, but I'm saying that we use them cautiously, and that would be my recommendation.
Thank you. And the other question is, how long can you use these agents? So the sedation, the analgesia for patients, maybe they're staying in the ICU for a long time, let's say more than a week. Can you keep using these sedatives and these analgesics for a long period of time?
Yeah, so sedatives, I'll talk about the continuous infusion, propofol, dexmedetomidine, Versed. There's clear data that the additive effect of benzodiazepines, the larger and larger dose, the higher chance of delirium, prolonged time on the ventilator, increased ICU length of stay, and likely leading to tracheostomy. So you can use it, but other consequences to it. Propofol also can be used. The concern with propofol for prolonged use, especially at higher doses, propofol infusion syndrome. There was a nice paper that came out of NYU a couple of years ago, I think 21, that looked at monitoring triglyceride levels, and that if you have elevated triglyceride levels, there's probably a higher risk of propofol infusion syndrome, and that would be the risk for propofol. In general, what we try to do is admit patients, or patients get intubated. We try to treat pain first. Pain is the first thing we treat with PRN narcotics or some IV Tylenol. If the patient's unable to be intubated, tolerate intubation, which very few in the American context are, without sedatives and continuous infusion sedatives and pain medications, then we'll use propofol first, and then PRN narcotics and using adjuncts. If the PRN doesn't work, patient will go on a continuous infusion of narcotics. Then what we try to do is lessen or stop the medications as soon as possible, using our multimodality therapies. If they have neuropathic pain, treat that, speak to the families about how to handle their anxiety and agitation, see if they have any psychiatric history, make sure they get back on their medications. And as long as it's safe, the patient doesn't have severe ARDS and we're proning them and stuff like that, we'll try to come off the medications as soon as possible. But you can use them for as long as you need to use them. But be aware that there will be consequences and side effects.
Staying on propofol, one last question, I think, before we, because it's nearly 4. There's a question that propofol has been known to cause respiratory depression. And so in ICU patients, that's something that we are very concerned with. They may already have a compromised breathing. So how would it be better than the other 2 options that you have discussed?
Yeah, that's a great question. So that's where I continue to emphasize the needs for the Richmond Agitation Sedation Scale, or using SAS, because you can titrate the propofol to the lowest possible level to have the patient interactive with you. And even if there is some effect on respiratory depression, it would necessarily hopefully should not be significant. Also, remember, the propofol is used for conscious sedation. The anesthesiologists use it to, reduce shoulders, or people have, need work done on their ankles or joints. So it can be used safely, but the lowest possible dose to keep the patient safe.
Thank you. So thank you everyone for this, for participating here. Thank you, Dr. Puri, for taking your time out. I know it's early morning there, but thank you for kicking us off on this webinar series, hopefully first of many. We will we'll be having another webinar at the end of next month, and we will share details about that once it's ready. I'd just like to speak a minute about the slide that you see on the screen right now, the conference. The first part of the conference, as you can see, is the fundamental critical care support, and that is a course that has been developed by the Society of Critical Care Medicine, which includes Dr. Nitin and his team at Cooper. And it's a very good course, a 2-day course, which was done last year at Muhiumbili. Some of you may have attended that as well. It's a course primarily geared to doctors and nurses who are working in ICUs or who want to work in ICUs but are not necessarily intensivists. So it's a very good introductory course, and it will give you a lot of good information. There's didactics, there's hands-on workshops also in this course. So we are almost about to release the registration for it. So keep your eye out on the MUHAS website for that, and do register to get the benefit from that. In the end, I will just say that thank you again, everyone, for joining, and I hope that we will see you again for the next webinar. Thank you all for coming. And thank you, Dr. Puri.
Thank you, Dr. Moldini, and thank you everyone for your time, and hopefully see you in Tanzania.